Hello again. This is more of Module 5 on the urinary system. This is Part 3 of Module 5. Objectives in this part will be to identify important observations regarding any resident with a urinary catheter, identify factors that make management of incontinence difficult, and describe benefits of TED hose, known as anti-embolism stockings. We are going to start by talking about some common urinary disorders. UTIs are a common condition caused by bacteria that enters the urethra and travels to the bladder. A common bacteria that does this is E. coli, which is found in our GI system. This bacteria typically is able to enter the urinary system because of poor hygiene technique. When cleansing the front or back of a person, wipe from front to back. This will help prevent spread of the bacteria from buttocks to urethra. Women in particular are susceptible to UTIs due to the shorter urethra. If a resident has a UTI, their symptoms could be pain or burning with urination, blood in the urine, and/or increased frequency and urgency to urinate. However, some people do not exhibit symptoms of a UTI. If left untreated, the bacteria could travel up to the kidney, causing even worse, a kidney infection. UTIs and prevention strategies include drinking plenty of fluids and juices rich in vitamin C, like cranberry juice, wiping from front to back after elimination, avoiding baths, and taking showers instead. As a reminder, always report changes in urinary elimination, such as cloudy, dark, or foul-smelling urine. Burning or discomfort with urination or frequent urination in small amounts should also be reported. Chronic renal failure, CRF, is also called chronic kidney failure. This is the condition in which the kidneys cannot effectively filter the waste products from the blood. Many residents will have decreased kidney function. Causes of CRF can include diabetes, hypertension, chronic UTIs, nephritis, which is kidney infections, and possibly old age. Signs and symptoms that may suggest CRF include unintended weight loss, nausea, vomiting, fatigue, headache, frequent hiccups, and itching. Itching may be occurring because the toxins in the blood have not been filtered out. CRF worsens over time, and residents with this disorder may develop ESRD, end-stage renal disease. ESRD occurs when the kidneys have failed and dialysis or transplant is required to sustain life. Diabetes is the most common cause of end-stage renal disease. Dialysis is a procedure that filters the body by using a machine. You will be watching a video on this shortly. Urinary retention. Urine retention is an inability to adequately or completely empty the bladder. This can be short-term or long-term. Some of the causes include surgical procedures, obstruction, infections. Some disorders, such as multiple sclerosis, MS, and diabetes, in males, an enlarged prostate gland can cause urinary retention. The prostate gland is centered around the urethra near the bladder, and if enlarged, the gland may decrease the width of the urethra in men. Symptoms of urine retention may include painful urge but inability to urinate, frequent urge to urinate, and difficulty starting to urinate. Urinary incontinence is the inability to control the muscles of the bladder that cause involuntary loss of urine. Urinary incontinence is not a normal part of aging. As a nurse aide, you will be expected to handle this issue with professionalism. Do not become angry or frustrated with residents who are incontinent. It is not something to joke about. Some possible causes of urinary incontinence include confinement to bed, illness, paralysis, circulatory or nervous system disorders, prostate problems, and childbirth. Urinary incontinence can be classified in several different ways. Stress incontinence occurs when there is an increase in intra-abdominal pressure, such as when a person sneezes, laughs, or coughs. Urge incontinence occurs due to an abrupt urge to void immediately. Mixed incontinence is a combination of both urge and stress. Functional incontinence happens when there is an environmental, cognitive, or physical reason that prevents the person from reaching the bathroom in time. Overflow incontinence, lastly, is due to an over-distended bladder that causes the body to empty the bladder. Urinary incontinence can be emotionally difficult for some residents to deal with. Here are a few strategies to help prevent urinary incontinence. Know the resident routine, their habits, and signs that they may need to use the restroom, such as holding the lower abdomen. Follow a consistent toileting schedule based on the care plan. The regular schedule may help them regain continency. Answer call lights promptly, especially if the resident suffers from urge or mixed incontinence. Offer the bedpan or bathroom frequently. Despite what a resident thinks, offer and encourage good fluid intake to prevent infections that may increase the incontinence. This will also help them remember they need to go to the bathroom. Residents that don't drink won't have to use the bathroom. If the resident wets or soils the incontinence briefs, change them immediately and clean their perineal or buttock area with soap or water and disposable wipes. A urinary catheter is a tube to drain fluid from the bladder. Some catheters remain in the bladder, while others are inserted in and then removed after urine has been drained. Catheter care is done to prevent infection and to provide good hygiene. The care will vary between facilities, but overall is the cleaning of the insertion site of the catheter, the meatus, and 4 inches down the catheter tubing. Emptying the drainage bag will be part of the care and is usually done every shift or as ordered by care plan or PRN as needed. For catheter care, we wear gloves. Do not let drainage spout touch the graduate. Make sure the drainage bag hangs lower than the hips, below the bladder. Emptying daily, keeping it off of the floor, and keeping the catheter tubing from touching the floor. Here is a picture of a catheter. The top picture illustrates the catheter before sterile water is inserted. The bottom illustrates the sterile water-filled balloon at the tip of the catheter. This balloon will help keep the catheter in place, but can be pulled out if tugged too much. Always try to prevent tugging of a catheter by holding the catheter tubing in your hand when performing care or when helping the resident to move. Can you imagine how pulling on an inflated catheter from your urethra would feel? This event has occurred to many people. Be very careful. When giving catheter care, observe and report the following. If there is any crusting at insertion site, pus or unusual drainage that could mean an infection, any sores or redness present, any urine leaking around the catheter, any complaints of bladder or lower abdominal pressure or spasms. Bladder and bowel rehabilitation may be a plan to help correct bladder and bowel incontinence. If a rehabilitation program is initiated for the resident, it will be very important to follow the toileting routine according to the care plan. Regaining continence may take time, so offer assurance. Continue to offer and encourage the fluids to help keep the resident healthy and to prevent any further complications due to infections. Finally, never show frustration or anger toward the resident who is incontinent. Be positive and patient with the retraining efforts. Heat and cold applications are used to help provide comfort in many ways, including relieving pain, relaxing muscles, promoting healing, reducing swelling, and decreasing joint stiffness. Nurse aides can apply heat or cold applications, but need to update the nurse on the resident's discomfort and gain permission to apply the applications. Always wrap the application in a protective cloth, such as a towel, to prevent skin impairments. They should be left on for 20 minutes and then removed. Report any additional complaints of comfort or changes in the skin. Anti-embolism stockings, also known as TEDs, TED hose, or compression stockings. Their purpose is to provide support and comfort to the lower leg with smooth and compression to the veins. This helps the blood circulate without pooling into the area and reduces the workload of the heart. These stockings are made of elasticized cotton and can be thigh length, knee length, or just above the knee. Considerations for anti-embolism stockings. The anti-embolism stockings need a doctor's order in order to be used. They're placed on the lower legs or lower extremities. The stockings need to be applied while the resident is still in bed in the morning prior to getting up. This helps keep additional fluid from accumulating to the lower leg and ankles. Try to apply them gently, but they may be difficult to place because they are snug on the leg. Unless care planned differently, the stockings should be removed every night, washed out in the resident's sink by hand, and left hang to dry. Do not give those stockings to laundry to wash or dry because this may damage them. Anti-embolism stockings can be very expensive. The most important thing to remember is that it should be wrinkle-free when you apply them. Check throughout the day for wrinkles and smooth them out. Wrinkles can cut off the circulation, causing complications for the resident. This will end this section and our Module 5 content.